Okay, let's talk now about moving from the patient's illness script that we've carefully produced using our processing skills and our problem representations development skills, and move on to prioritizing a differential diagnosis, the time you've all been waiting for. Now, look at what we've done with Ms. Garcia's case. We've used problem representation to already narrow the field. We started out this course with a complaint of shortness of breath, which has a differential in the thousands. And now, thanks to our problem representation and careful physical exam, we're working on a differential diagnosis of pleural effusion and weight loss, which has a much narrower set of differential diagnostic possibilities. It should be evident to you how this is going to be much easier to establish a differential diagnosis now that's more likely to focus on areas of very high impact and import. And we can do this because diseases, thankfully, behave somewhat predictably. And I'm going to say somewhat predictably because every patient with a disease presents a little bit differently, but in general there are uniform expressions of disease. And physicians have relied on classic descriptions of phenotype, that is the way disease presents to the outside world, to establish an initial diagnostic hypothesis. And then we can assess those diagnostic hypotheses with specific diagnostic tests. Recall streptococcal pharyngitis. We know what it looks like from a symptom perspective, and then we can follow that up with a test to confirm that it is streptococcal pharyngitis if we need that test to manage our uncertainty. We describe this phenotypic expression of a disease, the way in which a patient presents with a disease, with our patient illness scripts, and then we can prioritize the likelihood of a given diagnosis by how well that patient's illness script matches the classic disease illness script. This is truly a matching game, and the more compatible the illness script of the patient's presentation is with a disease illness script, the more likely it is that that disease is present. Now, prioritization of the differential diagnosis is really important. Even if you started off with a list, like a mnemonically driven list, such as the I Vindicata list, where you say, could it be idiopathic, could it be vascular, could it be immunologic? It's important to take that list and put the most important diagnoses at the top to target rather than shotgun your approach to diagnostic testing, Because testing and treating for high priority diagnostic possibilities avoids unnecessary cost in treatment and prevents wasted time. You want to put your attention on the diseases that are most likely to be causing the patient's problem so that you don't have to run up a large lab bill and waste a lot of time and energy on the part of the patient or the physician in terms of looking at tests that were not really helpful. Also, prioritization aids in the interpretation of subsequent diagnostic tests. There are really no tests that were 100% sensitive and specific, and we'll talk more about clinical decision-making using tests on the next module. So test results can lead to a false positive answer, which means that I think the disease is present when it really isn't, and that can result in more unnecessary follow-up tests or treatment. Or a test result can lead to a false negative conclusion, which means that we might erroneously discard something that was a clinically correct diagnosis. And we minimize the likelihood that we fall prey to these traps of false positive and false negative tests if we understood going into the test how likely our clinical diagnosis of the disease in question is. So we've developed a tiered approach to clinical probability based on patient illness script matching to the disease illness scripts. And we'll start at the top. A tier 1 possibility is a disease that's clinically high likelihood. So if we start with a differential diagnosis list and the patient's illness script, and we say, there's a disease that explains all of the patient's major findings, we're going to say that's a high likelihood disease if everything that the patient has can be explained by the disease in question. And importantly, everything that the disease usually presents with is seen in the patient. So you look at it both from the disease perspective and the patient perspective. So the patient should have all or almost all of the major manifestations of the disease. And again, I'm emphasizing the word major because in our illness scripts, both from the patient's perspective and from the disease perspective, some of the findings will have more importance than others. Finally, it's a tier 1 possibility or clinically a high likelihood if there are no rejecting features present. So if there's a disease that we're considering that has explains a lot of the patient's major findings, but the patient has a rejecting feature, meaning something that's never seen in that disease, it's no longer a clinically high likelihood. But if there is a key feature present, that is something that when seen in a situation like this means that a given disease is present, that's icing on the cake. Now, at the other end of the spectrum is what we would describe as a tier 3 possibility, clinically low to very low likelihood. And we've indicated this on our bar with red, meaning stop, don't do anything else, don't follow this diagnosis. And this is true when the patient has a single or only a few features of the disease in question, or a patient has a rejecting feature of the disease in question. So remember when we talked about the hypothesis testing, we said that oftentimes people take a single symptom and link it to a series of diseases. And what we would encourage you to do is, if it turns out that the patient really only has that single symptom in support of that disease, either eliminate that out of hand or put it very low on your prioritized differential diagnosis list. There will be very few tier 1s. There could be quite a number of tier 3s depending on the symptoms. But most of your attention will be spent paying focused concern to tier 2 possibilities, and those are the clinically moderate likelihood of disease. So if you look at a disease and look at your patient's illness script in comparison to that disease illness script, and you say, well, this disease I'm considering explains most of the patient's findings, but there's some major ones that are not explained by the disease, then you might be dealing with a tier 2 disease. If, on the other hand, the patient has most of the manifestations that the disease usually shows, but lacks some of the important ones, then that also might be a tier 2 possibility. And they usually have no rejecting or key features. So high likelihood, low likelihood, clinically moderate, or some people would call this uncertain likelihood. This is the tiered approach to prioritized problem solving. And it is a very important exercise in which to engage once you've established a set of differential diagnoses that you're considering to explain your patient's illness script. Now, when we're dealing with clinical problem solving and looking at how to use diagnostic tests, we're often told it's important to consider the pretest probability of disease based on our clinical presentation. And while there are some conditions, for instance, coronary artery disease, where there's published information about the extent or the pretest probability of a given clinical presentation resulting in a diagnosis that's true of coronary artery disease, in most cases we're dealing with clinical probabilities. So we've taken the 3 tiers, tier 1, 2, and 3, assign them a categorical probability. So tier 1 is likely to very likely, tier 3 is unlikely to very unlikely, and tier 2 is uncertain. And then connected those categorical probabilities to numerical probabilities so that we can use mathematical clinical decision tools in our assessment of the post-test likelihood of disease. Now, what you may ask is the difference between a likely and a very likely disease. Well, clinically, a very likely disease exists if there's a defining feature that's present. So something that says, for certain, remember our mono case, there are posterior cervical nodes in a 12-year-old with tremendously sore throat. That's going to put mono up at the very likely stage. And what's very unlikely? Something that truly has just a single symptom link between your patient's illness script and your disease illness script, or a rejecting feature. Remember our case of Guillain-Barré syndrome. We said if a patient presenting with lower extremity weakness has increased reflexes rather than absent reflexes, they don't have Guillain-Barré. So in that situation, Guillain-Barré would be a very unlikely disease because that's a rejecting feature. Now, as we mentioned, we provide these tiers because it's important to use them to choose your testing strategy and your treatment strategy. And we believe in general that you should test and treat for tier 1 diseases before you test and treat for tier 2, and certainly way before you test and treat for tier 3 diseases. But at times, clinicians test and treat for low likelihood diseases, things they don't think are present based on the clinical symptoms or signs, because those low likelihood diseases might have really serious consequences if missed that day. So someone coming in with chest pain, I might not think they have a dissecting aneurysm, but if I'm wrong, that's a fatal mistake. Similarly with acute bacterial meningitis in a patient who's got a pretty mild headache or an acute myocardial infarction in somebody who I think has non-anginal pain. So clinically, as I put together my problem representation, I say, gee, those diseases, dissecting aneurysm, acute bacterial meningitis, clinically would belong in tier 2 or tier 3, but I'm going to put them higher in the list because I want to test and treat for them more expeditiously given the consequences of a misdiagnosis. And in recognition of that fact, we identified a 4th category, and that's a tier 1E or 1 emergency diagnosis. So importantly, a disease that's clinically a tier 2 or tier 3, but that we will consider earlier in our testing and treatment strategy because it's a high-risk disease. Now, when I work on this course offline with students, there's a tremendous tendency on the part of the students to put everything in tier 1E as a can't miss diagnosis. All diagnoses are can't miss. This is about we can't miss it tonight. So when people say, well, we should put cancer into tier 1E because you don't want to miss cancer, that's true, but you have time to make a diagnosis of cancer. If you want to say spinal cord compression as a tier 1E diagnosis, I would accept that as an appropriate use of the tier. But don't get in the habit of putting everything into tier 1E because it defeats the purpose of prioritizing your differential diagnosis. And importantly, if it really is a tier 1 disease, it goes above tier 1 because that's the first thing, tier 1E, that's the first thing you test and treat for, is a tier 1 disease, then a tier 1E disease. So let's go back to Ms. Garcia, and I'm going to give you a list of proposed differential diagnoses that we culled from your homework that you did in week number 1. These were diagnoses people offered when they just heard the chief complaint of shortness of breath. So breast cancer, lung cancer, tuberculosis, sarcoid, COPD, community-acquired pneumonia, anaerobic pneumonia, congestive heart failure, asthma, lymphangiomyomatosis, which is known by its abbreviation LAM. It's an interesting choice for whoever out there picked that one. Lupus. Lupus is almost always on a differential diagnosis list. I think people have been taught, if they want to sound smart, say that the patient might have lupus. And then pneumocystis pneumonia, a opportunistic infection seen in patients with T-cell immunocompromise. Now, as you notice, this is a really random list. We go from cancer to infection to inflammation to sort of another infection, a more acute infection, a chronic infection. It doesn't follow the I Vindicate list, so people didn't make it that way because I didn't pick this from one person. But there's no way of knowing, based on this list, whether I understand Ms. Garcia's presentation or not. And so I'm going to show you how we'll move from the patient's illness script to this prioritized differential diagnosis and why this helps. So, tier 1 diagnoses, let's work from the top. Tier 1 diagnoses, remember we said, are high clinical likelihood, either high or very high. And they're high clinical likelihood because everything that this disease should cause is present in the patient, and this disease actually explains every one of the patient's major signs and symptoms. So, lung cancer with malignant pleural effusion. Remember we said she had shortness of breath without hypoxia, physical evidence of a pleural effusion, weight loss that could be explained by lung cancer, and cough, which could also be explained by lung cancer. So everything that Ms. Garcia has can be explained fully with these clinical presentations. Now you might say, what about her vascular claudication? Remember, that's not in her predominant disease-based illness script. That's in the associated past medical history of her illness script. Tier 1E, we might say acute pulmonary embolism. Now, why is acute pulmonary embolism there? We would put it there if we think it is a less likely diagnosis than a tier 1, but something that could kill her tonight if we don't immediately identify it and treat it. So pulmonary embolus does fall into that category of it needs to be diagnosed and treated quickly to avoid potentially dangerous consequences. But let's talk about the extent to which an acute pulmonary embolus would explain her symptoms. So certainly it would explain shortness of breath, explains her dyspnea, and explains progressive dyspnea, right? So explains at least one of her major symptoms. It does not explain pleural effusion of the magnitude that we see. So her pleural effusion, remember, the dullness to percussion was about 2/3 or 3/4 of the way up in her lung field. Pulmonary emboli, especially recurrent pulmonary emboli, can cause a pleural effusion, rarely cause a pleural effusion, but generally it isn't going to be large the way we believe Ms. Garcia's is based on her physical exam. So she gets points for the dyspnea, plus minus for the pleural effusion. Actually, I think minus for the pleural effusion. The other phenomena we saw is weight loss, which cannot be explained by an acute pulmonary embolus, right? And cough, she could. So it doesn't fit as well as tier 1, probably belongs validly in tier 2, perhaps with a shortness of breath being the major symptom link even in tier 3. But again, because of the consequences of missing this diagnosis, we would clinically approve and actually support testing and treating, even though the clinical likelihood is probably on the order of uncertain to low likelihood. So let's look at some of the other phenomena. Tuberculosis. Tuberculosis is really an interesting one because it can cause shortness of breath for sure, dyspnea and progressive dyspnea. It can cause weight loss. It can cause a pleural effusion. And interestingly, there are pathologic lymph nodes in tuberculosis. I forgot to mention that up here with a lung cancer diagnosis. That pathologic lymph node would certainly be explained by this, but would not be explained here. But the lymph nodes in tuberculosis tend not to be these sort of isolated, firm regional lymph nodes. They tend to be what they call scrofulaic lymph nodes, which are big and juicy and draining lymph nodes, usually in the neck. So the type of lymph node present doesn't really explain tuberculosis. And the pleural effusion could explain it. So tuberculosis is not a bad fit, but it doesn't explain a really major part of Ms. Garcia's presentation, which is that really pathologic node. And also with tuberculosis, we tend to look for things like fever and night sweats as evidence of the cytokines that are chronically released in tuberculosis. So there are some things that TB usually has, fever and night sweats, that Ms. Garcia doesn't present with, and there are some things Ms. Garcia has that node in particular doesn't really fit with tuberculosis. And hence it's a tier 2 rather than a tier 1. Congestive heart failure? Certainly. Shortness of breath, yes. Cough, yes. Weight loss, it can be. Cardiac cachexia, although one would think if she had severe enough heart failure to cause cardiac cachexia, we'd see some evidence of hepatomegaly, hepatic congestion, which often goes with that, and certainly more abnormal heart sounds. So it can explain her shortness of breath. It could explain a unilateral pleural effusion. It can't explain a node. And there are many features of heart failure that Ms. Garcia doesn't present with. For instance, elevated neck veins, S3, or any other pathologic indicators of heart failure. So at best, it's a tier 2. And if you wanted to argue it's really a tier 3, I'd buy into that. What about breast cancer with effusion? That's really an interesting one as well. And what you can see from this prioritized differential diagnosis is when we got to the point where we said, this is the patient's problem representation, and it was so precise about the findings that we had that were abnormal, in addition to her chief complaint, Our diagnoses are more specific too. We're not just saying cancer of any type. We're saying, well, tier 1 is lung cancer and tier 2 might be breast cancer. So breast cancer, certainly metastatic breast cancer can cause a pleural effusion. Right supraclavicular node, absolutely. It could cause a right supraclavicular node. Weight loss, absolutely. Why isn't it a tier 1? Well, you could argue effectively for me that it should be a tier 1, but we're missing any evidence that she has a breast mass or known history of breast cancer. And that might be sufficient to move it into tier 2. But it also, if we found out that in fact no one did a breast exam, we might be inclined to move it up as well to tier 1. Anaerobic pneumonia with effusion. First off, epidemiologically very unlikely. Anaerobic pneumonias typically occur in patients who have very poor dentition. We didn't hear about dentition in Ms. Garcia, so we would assume that there was nothing striking about her dentition, although it would be good to go back and check. Also, it occurs in people who frequently have had episodes of loss of consciousness that lead to aspiration, and there's nothing in her history that suggests that she's at risk for that. So we're missing the epidemiology that we would typically expect to see with the disease illness script for anaerobic pneumonias. Effusions do occur. Can't explain a regional node, which is why it's less than tier 1. And probably even within this last list, less than the other 3. Now, what about tier 3? The difference between tier 1 and tier 2 is sometimes a little blurry, as we've talked about, and there's judgment involved here, but you can begin to see that even within this list, lung cancer, tuberculosis, heart failure, breast cancer, and anaerobic pneumonia with effusion, some of them have clearly a better match than others, and others, in order to make them fit, you have to kind of squeeze a round peg into a square hole. Tier 3s are usually, once considered, can be easily dismissed because they're totally unsuitable to explain the patient's signs and symptoms. So let's work through these a little bit. COPD. Now, why would someone consider COPD? Well, because it's a common cause of dyspnea in middle-aged individuals, and she does have a smoking history. And although she's relatively young, perhaps she's somebody who has the unfortunate genetic history of being someone with an alpha-1 antitrypsin deficiency. But COPD does not cause pleural effusions, and COPD's physical findings should be hyperresonant rather than dullness to percussion. So right off the bat, we can't explain Ms. Garcia's significant pleural effusion. We can't explain a pathologic node. And in general, if COPD is profound enough to cause dyspnea at rest, we would expect, in fact, that she would have some hypoxia. So that's a classic sort of single symptom, shortness of breath, or double symptom, shortness of breath in a smoker equals COPD. And similarly for asthma. Lupus, as we mentioned, perhaps just an interesting guess, but perhaps related to the fact that she's a middle-aged woman. Lupus can cause pleural effusions. It's a manifestation of serositis that sometimes happens with lupus. But this would be an isolated serositis. She has no other findings we'd expect to see in lupus. So she has the appropriate epidemiology for lupus. She has probably the appropriate time course for lupus serositis, but her clinical signs and symptoms are not sufficient for us to consider that as a serious diagnosis. Sarcoidosis, again, considered perhaps because she is a woman of color in the middle age range, and she has shortness of breath. But large pleural effusions in sarcoidosis, very unusual. So can't really explain that. And she has no other manifestations of joint or skin problems that you often see with sarcoid. Now, even more unlikely, lymphangiomyomatosis. Lymphangiomyomatosis is a very interesting disease that occurs in women in the reproductive years with symptoms that exacerbate around the time of menses. And patients may be short of breath and may get spontaneous pneumothoraces, but a pneumothorax has a very different physical finding than Ms. Garcia's. So epidemiology doesn't match, time course doesn't match, and clinical symptom complex doesn't match. Community-acquired pneumonia might have been under entertainment at the beginning of her presentation, but she's been sick for over a month, has had no fever, no sputum production, and hasn't manifested the usual inflammatory symptoms. And pneumocystis pneumonia, again, typically an interstitial pneumonia, which could not explain her pleural effusion. So I've spent a fair amount of time going through this differential diagnosis to see how we look at the disease and the disease-specific illness script and compare it to the patient-specific illness script and prioritize our differential diagnosis based on that compare and contrast learning. And as a consequence, we would be looking for diagnostic tests that will be able to either affirmatively diagnose lung cancer or do so while affirmatively ruling out acute pulmonary embolus before we moved on to the remainder of the diagnostic options. Got it? Okay. So it helps you diagnose patients to work through this processing, development of a patient's illness script, and comparison to disease-related illness scripts or disease-specific illness script. But it's also, this mechanism and method is important to help you direct your own learning, because it becomes pretty easy to understand what you don't know and why you might need to know it if you start to do this compare and contrast and you come up short with some of the information that you need. So for each diagnosis you venture forth, each diagnosis you put on your list, make sure you can describe at least the core illness script of that disease, at least those foundational elements of epidemiology, time course, syndrome statement, and mechanisms of disease for every disease that you put on the list. And if you don't, if there's a gap in your understanding, follow the gap and close it. So it gives you a good tool to sort of say, do I really know this disease well enough, or am I just putting it on the list because I heard about it yesterday? Secondly, if you have no ideas on how to expand your differential diagnosis, so you look at the patient's illness script and it's not triggering any clues, you can't recognize any patterns, you haven't seen a patient like this before, it's fine to think either pathophysiologically, like how do I think that she has an effusion, how do effusions form, or mechanistically, as we talked about, using one of the category mnemonics that we've discussed. Start with that, but if you develop your lists this way, rather than searching for a pattern match because you understand an illness script of a disease that matches your patient's illness script, once you develop this list, go back and do what we did with Miss Garcia and prioritize it based on a matching phenomena, so that you don't end up with long involved lists of things that you think could be the cause, but in fact are really clinically highly unlikely to be relevant in this particular presentation. Okay, just the final check. Sophia Ballara, remember her? Her patient illness script we talked about before. Young, sexually active, exposure to ticks, acute and evanescent, febrile oligoarthritis, and enthesopathy with discrete hemorrhagic pustules. And her other history is asthma. Why are we coming back to Sophia? Because we know she's got disseminated gonococcal infection. I want to show you a compare and contrast prioritized differential diagnosis list to round out our case teaching on Sophia, and then we will let Sophia go on to her treatment and go home. So, tier 1 we decided was disseminated gonococcal infection. Epidemiologically, she has the relevant exposure. She's sexually active. From a time course, this several days worth of illness is quite compatible with DGI. From a clinical syndrome perspective, the tendon involvement and episodic evanescent joint involvement is very compatible, as is the rash, quite classic for disseminated gonococcal infection. In fact, that's almost a key feature in this particular environment for disseminated gonococcal infection. So she's tier 1, and given that key feature, I would say that DGI is a highly likely or very likely diagnosis. So she'd be in that greater than 90% for disseminated gonococcal infection. What might be a tier 1E for her? Well, septic arthritis that's non-gonococcal could be considered to be a tier 1E. Septic arthritis you really need to diagnose and treat at presentation, because to leave bacteria in a closed joint space without specific treatment can cause substantial and irrevocable injury to the joint cartilage. So septic arthritis, perhaps she had a transient staph bacteremia and that seeded her joints. That would be something we'd worry about. But it doesn't really fit her pattern, because one of her joints was swollen and warm, her elbow, and got better. and then a new joint has been involved. And so that first elbow should not have gotten better. That's not compatible with a septic arthritis picture, nor is the type of rash that she's demonstrating. So that makes septic arthritis a valid 1E diagnosis. It's much less likely than tier 1, but something emergent. Now, other people have proposed for Sophia that a sexually active woman with a new joint problem or new arthritis could have Reiter's disease or reactive arthritis. Here again is where our disease illness script helps us quite a bit. So the epidemiology might be a match, right? So the epidemiology looks good. The time course is a little bit fast. Reiter syndrome usually has a more subacute presentation. So instead of having a few days worth of illness and joint symptoms, people usually have weeks to, a month or two worth of symptoms. But there are at times acute presentations. The clinical signs and symptoms don't match well, however, because joints involved in Reiter syndrome can be wrists and ankles, but often are larger joints and spine, so it may cause a spondyloarthropathy, which we don't see in Sophia. And importantly, the type of rash you see in Reiter syndrome is not these discrete hemorrhagic pustules. You get a very unusual rash in Reiter syndrome called keratoderma blenneragicum, which is kind of scaly rash on the base of your feet. So the rash doesn't fit. And the mechanism of disease is an immunologic mechanism rather than an infectious/immunologic. So although the epidemiology matches and the superficial clinical syndrome, that is the arthritis, sort of matches, when you really dive into the classic signs and symptoms of Reiter's disease, you see it really doesn't fit her presentation well, and we're being generous to put it in tier 2, but it's an interesting thing to consider, so it's certainly not tier 1. Tier 3, very unlikely, systemic lupus. Why? Because lupus tends to present with symmetrical polyarthritis rather than oligoarthritis that is evanescent. Lyme disease, why are we putting that so low? Again, the type of arthritis she's demonstrating is a little bit unusual, but the rash is even more unusual. And very unlikely because she has neither the epidemiology nor the classic presentation are diseases we typically see in older men and women with other metabolic disorders, gout and pseudogout. So this is usually a monoarthritis. This might be a polyarthritis. This is typically associated with hospitalized patients with multiple medical problems, and people with hypertension and renal insufficiency and uric acid metabolism issues. So again, even with a similarly straightforward case, the prioritized differential diagnosis really sort of points us in the right direction, really at the top. And along the way, when we compare and contrast between these different diseases, if we're reading about them in the context of Sophia's case, we're beginning to develop really powerfully strong connections where we understand that, yes, Reiter's disease and DGI both occur in sexually active young adults, but there's a much different rash here compared to the rash here, and that's going to be helpful in laying down those memory nodes that you need to develop very strong clinical problem-solving skills. So, quiz 3.2. Tier 1E is the tier reserved for 1. Diseases that by clinical phenotype are tier 1, but very important to consider. 2. Diseases that by clinical phenotype are tier 2 or 3, but have emergent severe consequences if missed. Tier 3, diseases that are rare but exciting. Or tier 4, diseases that are faced with extinction. That's a little clinical problem-solving humor. But the answer, of course, is 2. Diseases that by clinical phenotype are tier 2 or tier 3, but that have emergent severe consequences if missed. Tier 1 diseases are always important to consider. So that's a higher tier than tier 1E. That's why that number 1 is wrong. So there's been a lot of work today and some really important progress on developing your clinical problem-solving skills. And the key take-home messages from Module 3 is number 1, processing is the first step in developing a good disease representation because it helps us build a patient illness script that allows us to compare and contrast between the disease's presentation and possibly relevant diseases. And that compare and contrast strategy can lead to a well-prioritized differential diagnostic list that can effectively and efficiently guide testing and treatment on behalf of your patient. That's all for Module 3. Please make sure you check the web for your homework, and we'll be back next week to talk about how we use tests to further refine our differential diagnosis after we've gone through this important exercise of clinical problem solving.